I hope now the voice is okay and now we are ready to start. So yeah, it may happen sometime that we might be losing some time in these kind of tech part. So we should be prepared for this also. But anyhow, now we are okay. So I hope now the voice is okay. Audio, video both are fine and we are ready to start. So Utkarsh was asking me why I'm so sad today because I wasted like kind of 25 minutes on this tech part. So that's not a good thing, right? Hardly like 9 days away from the exam we are, and it is not at all a good idea to waste even a single moment. So guys, today's session, the purpose is to give you some of the important orthopedic images which are useful for all your exams, whether you are going for the NEET exam or the INISET exam. So any of the exam, FMG exam, everywhere these images are actually very, very important, right? And most of them, they have been repeated number of times in your exams. So without taking wasting much of the time, let me start with this. And how all the questions can be asked, that too we can discuss here itself, right? So very first one that you have on the screen is, I think, a deformity. Okay, it is not getting changed, just give me a moment. It is the image. Yeah, so let me just give me a moment. So I'm just sharing my screen so that you all can see the image here. So now what? So now once the audio is okay, the video, let's see. Yes, now we are here. So now you all can see the screen. So the very first picture we have is something like this, where you all can see the child is having the elbow, having some sort of deformity. You all can appreciate that. Yes, right. So the child is having a deformity around the elbow area, and you all can easily like recognize it. The deformity around the elbow and the forearm is going on to the medial side, right? You all can recognize this. What sort of deformity it should be? For the elbow, the first word to be used, it has to be the cubitus. And when the part distal to the elbow is going medially, what should we be calling it? It will be called as now the varus deformity, right? So cubitus varus is the problem here. And where do you see this cubitus varus deformity? We all know this cubitus varus deformity will be seen in relation to which injury? Gunstock. Absolutely, you're right. It is a gunstock. And this gunstock is seen in relation to which fractures? So it is the fracture supracondylar humerus, right? Now I want all of you to not only remember about the supracondylar humerus, but I want you all to understand and remember that why in the fracture supracondylar humerus this deformity should be happening, right? That is the most important part. So when supracondylar is happening, every supracondylar is not going to show you, it is not going to show you this sort of deformity, right? The labeling, yeah. So it is not going to show you this sort of deformity, right? Supracondylers are only going to show you the deformity when there is some complication related to them. What is the most commonest complication related to supracondylar humerus? The most commonest complication always and always has to be the malunion, right? It has to be the malunion because it's a metaphyseal area, right? That has to be the metaphyseal area. So that gives you the malunion. Metaphyseal being highly vascular, it has to give you the union. And here malunion is the most commonest feature we have, right? That is just something very, very important about this supracondylar. Now, in supracondylar, please do remember not only the malunion. Somebody, Dr. Sid has right very, very correctly. Supracondylar humerus, AMRU. Now, what else will be the questions or what else can be the question? First, other question can be all the points which you learn in relation to compartment syndrome. Because supracondylar is one such area which can produce so many complications related to compartment syndrome, like the pressure effect. It can kill the soft tissues and bring the permanent contractures, right? So in relation to compartment syndrome, what all questions you should know? The most commonest fracture, the quickest one to get into compartment syndrome, the fracture diaphysis of tibia. It is not supracondylar, it has to be diaphysis of tibia, right? Second, if they ask you what is the, okay, second, if they ask you what is the most commonest, or I can say the first symptom of compartment syndrome, symptom, it is, symptom has to be the pain. What is the first sign of compartment syndrome? The sign will be the pain on passive stretch, right? The pain on passive stitch. That has to be very, very important. And in relation to this, in the previous years, we have already got the question, right? Then we have in compartment syndrome, again, the most commonest nerve involved, anterior interosseous nerve, which is again the most commonest nerve involved in supracondylar also. And at the end, you should also remember the most commonest muscle to get involved in compartment syndrome, that has to be FDP. And whenever you're talking about the treatment plan for compartment, always and always it has to be the fasciotomy for both the fascias, superficial as well as deep, right? So it has to be, treatment has to be the fasciotomy. Okay, so fasciotomy, which has to be superficial as well as the deep one, right? So all of these have been your questionnaires in the past as well. Now, one question which keeps on occurring on the social media platform, very commonly asked, that what is the late sign of the compartment syndrome? Is it the pulselessness or is it the paralysis? So always remember the late sign. When you are talking about the late sign, it is always about the pulselessness, right? So guys, pulse is something on which you should never rely in compartment syndrome, right? Pulse, don't rely on pulse. It's not at all a reliable sign, right? So please remember all these MCQs in relation to supracondylus, the malunion, cubitus varus, and all the points in relation to compartment syndrome. Another very, very important point is in the last session of INA set November 1, not this one May, November 23, they asked about 3-point relationship in the supracondylus. So what happened to 3-point relationship? It always has to be maintained, right? 3-point relationship is not touched. That has to be maintained. All right. So these are all the points in relation to supracondylus. That is image 1. Okay. So all the points have to be remembered, not only just one question. Now, second one, the deformity that you see on the screen. Here you can see the elbow and then forearm going laterally. So now if the forearm goes laterally, what I should be calling it? What sort of deformity it should be? It has to be the lateral deviation. Lateral deviation simply means that it has to be a valgus now, right? So cubitus valgus. Cubitus valgus, in relation to which fracture do we see this deformity? The elbow, the cubitus word for elbow, and the valgus for the deformity. Where do we see cubitus valgus? Where do we see this valgus? It is seen in relation to fracture of the lateral condyle of humerus, right? It is seen in relation to fractures of lateral condyle of humerus, right? And this lateral condyle, every lateral condyle is not going to show you this deformity. It is the complication which leads to deformity. And what is the most commonest complication related to lateral condyle? It has to be the non-union, all right? That has to be the non-union. And why there is a non-union? You all know very well that non-union is because the common extensor origin, it is at the lateral condyle, right? And if this lateral condyle goes into non-union, if the lateral condyle goes into non-union, then the child, the patient with the growth of the limb is going to develop this progressive lateral deviation of the forearm. Now, if there is a lateral deviation of forearm, we are going to call it the progressive cubitus valgus, right? There will be progressive cubitus valgus, and with the progressive cubitus valgus, what happens on the medial side? The medial side soft tissue structures, they start getting stretched, and that leads to involvement of the ulnar nerve, right? So that is not going to be a acute involvement of ulnar nerve, that's going to be a late involvement. So that's why it is called as the tardy ulnar nerve palsy, right? Now this is one of the most commonest site which can be done wrong in the exam. Reason being, the fracture here is on the lateral side of the elbow, right? And the nerve getting involved is on the medial side of the elbow. One cross area, injury is on lateral side, nerve involved is on medial side. Okay, so always and always remember one cross area. If in your exam, if the ulnar nerve is involved, the child is going to have, the patient is going to have the trouble in the distribution of medial, this ulnar nerve that is on the medial side, right? So whenever there is a clawing of the ulnar, these two fingers, or there is tingling or numbness, don't always search for the reason on the medial side. The deformity, the trouble is on the medial side, but the fracture is on the lateral side. Okay, so one cross area which can be done wrong in the exam, so be very, very careful. It has to be tardy. I'm very, very sure you all know the meaning of this word tardy. It has to be always the slow or late involvement, right? Slow or late involvement of the ulnar nerve. Okay, this is fine, I hope. These are the very important MCQs. Now, this non-union is the reason that these fractures are known as the fractures of necessity. So by chance in your exam, they ask you the question that what should be the management plan for any lateral condyle? It has to be fixation, right? Don't try to conserve it. It has to be fixation all the time, right? So that will be your fracture of necessity. Okay, that's a fracture of necessity. Now next one, these deformity, the deformity of the legs. Now the legs, the first word to be used is for the knee, and the word we use for the knee, it has to be the genu, right? And the legs here in the picture, they are deviated on the medial side. So what I'm supposed to call it now, that will be called as the genu varus. And where do we see genu varus? You all know this is the most commonest deformity that we see in our elders, right? And this is related to which pathology? That will be osteoarthritis, right? Most commonest problem that brings this kind of leg in our patient is osteoarthritis, and that to which side? The medial compartment arthritis, right? The medial compartment arthritis, so that the legs are deviated medially. Okay, this is OA, nothing very special in that, and you should know this is the commonest deformity related to osteoarthritis, varus. Absolutely. Now, when somebody asks you about a child having these kind of legs, Archit has answered very, very correctly that it has to be the rickets. So, most commonest problem which can produce these kind of legs in a child, it has to be rickets. Most commonest problem which can make this kind of legs in an adult, it has to be osteoarthritis, right? Absolutely correct. Perfect. And this one, if we can make out the knee area and the leg is going laterally, if the leg has to go laterally, it has to be called as valgus, right? Where do we see genu valgus? Definitely in a child, it can be seen in relation to rickets, but where else we can see this kind of deformity? The valgus part, this can be in relation to in a child, in rickets, and in an adult. Where can we see that? And in the adult, where we can see that? The adult, the patients of rheumatoid arthritis, right? The patients of rheumatoid arthritis, the patient of osteoarthritis, or any sort of degenerative arthritis. So this is genu valgus. Perfect. This is genu valgus. Absolutely correct. So rickets, rheumatoid arthritis can bring this kind of leg. The leg goes laterally. Perfect. Okay, great. Now these are the 5 pictures which I wanted to discuss. Again, a very, very important topic. And one of the question has been there in your recently conducted INI set exam as well, right? This is all about the injury to the growth plate. This is all about the injury to the growth plate, which is also called as physis. So what is the classification that we use for physeal injuries? What is the classification that we are going to use for any of the physeal injuries? The classification which is used is Salter and Harris, right? I'm sure everybody recalls that. Salter and Harris, right? So this one is about the Salter and Harris, the two colleagues which have given this classification system. Okay, the two colleagues who have given this classification system, the Salter and Harris. Perfect. Salter and Harris classification, right? Salter Harris, how many types of injuries do they have? They have broadly 5 kind of injuries, right? They have got 5 types of injuries. And how do we divide them? All of them. See, type 1 injury. The type 1 injury is labeled as S, right? S stands for same level. S stands for same level. What does that mean, same level? Same level means it involves only physis. It involves only the growth plate. And please do remember the basics here. Growth plate has got how many zones? Growth plate, the growth plate, if you see from epiphyseal side and you go towards metaphyseal side, how many zones it has? How the bone actually grows or develops? So these are different zones of the growth plate. How many zones do we have in the growth plate? There are total of 5. The guy is right. Absolutely correct. Okay. So first one is SCFE. No, that is not right. So when you talk about the zones of growth plate, you know very well that the first zone is the zone of the resting cartilage or the germinal layer, right? The first layer has to be the resting cartilage, right? The second one is called as zone of proliferation, where the number of cells increase. The zone number 3 is the zone of hypertrophy, where the cells enlarge, and once they enlarge, they become weak, right? Zone 4 is just a part of the hypertrophy only, and that is called as zone of mineralization, right? It is a lower part of hypertrophy only, and the last zone is zone 5, which is the zone of ossification, where the normal mature bone is laid now. The layer is laid, right? Okay, so this one is towards the metaphysis, this one is towards the epiphysis. right? So these are the zones, and out of these zones, you know very well that hypertrophy is the weakest zone of the growth plate, and this is the area from where most of the trauma fractures occur in a child. So Muhammad Sahib, okay, I don't know what is the duration of the course, this session. Maybe like 30 minutes, maybe like 1 hour, maybe like 40 minutes, wherever or whenever, till you are comfortable, till I am comfortable, we can go ahead with that, right? So there is no, it is not a session which has to be mandatorily taken for hours and hours. We'll just see till wherever we are comfortable, we can go like that, right? So now see, zone of hypertrophy is the weakest zone of the growth plate, and this is the area from where majority of the type 1 injury happens, right? This is S. Type 2 is A, and this has been your recent session of INI set exam question, the zone of hypertrophy, right? The zone of hypertrophy, the weakest area. Okay. Then we have the second one as A. A here stands for above. What is the area above the physeal area? So physis and a fragment of the metaphysis, right? This section of the bone here, this fragment of the bone here is called as the Thurston Holland fragment, right? This is Thurston Holland fragment, which is seen in type 2. Perfect. Okay, so Divya is absolutely right. Type 3 is SAL. L here stands for the lower part. Now, in the lower part, you can see that the fracture line goes in the epiphyseal area. So, physis and the epiphyseal area, they are involved now. SAL, lower part, epiphyseal area. Fourth grade of injury is T. The T here stands for total injury. So, epiphyseal fracture line, physeal fracture line, and metaphyseal fracture line. So, all the three are getting damaged, right? All the three are getting damaged. That is thorough or total. And last one we call is type 5 injury, which is ER. ER is for eraser. ER is for crush. So now there is a crushing of the growth plate which can happen here. So type 1 and type 5 are the same physeal injuries. Type 1 is the opening of the physis. You can see that. Type 5 is crushing of the physis. Crushing means all the 5 zones, they collapse. They are crushed. And type 1 is the opening of the growth plate. And this injury type 1, again I'm repeating my point, the type 1, the most commonest area, the zone to get injured is the zone of hypertrophy. That was a recent session of INI set question. So from Salter Harris topic, there can be three questions which can be framed for us now. One, the commonest zone of the growth plate from where it is having the injury, it is a hypertrophy. Second, the questions related to Thurston Holland fragment. And number three, the worst prognosis is of type 5. Archit, you are right. Absolutely correct. Okay, so Salter Harris has been the recent question. You should be aware of this. Now, next one is about the trauma itself. In the injuries, you can appreciate this fellow is having the left shoulder as a normal contour shoulder and the right one as a prominence of the bone. Right one as a prominence of the bone. Now, this prominence is of which part of the bone? This is acromion. You know that very well, right? Now, in the image A, if I label this as image A, this as image B, you can very well appreciate that in the image B, if I trace the margin of the bone, this is a greater tuberosity. The head of the humerus here, right? It is going like this. Okay. Whoa, come on, Prachi. Please see your statement again. Just check it again. And in the image B, you can see the head of the humerus as a globular, looking like a bulb, right? So now image A, can you appreciate what is that? This is the glenoid area, and the head of humerus is lying just in front of the glenoid area. What should we be calling it? What should we be calling it? This one. The first one is which one? First one is which one? This is the anterior dislocation of the shoulder, right? The head of the humerus has come in front of the glenoid area, so it is anterior dislocation of the shoulder. And on the other side, the head of humerus has turned in. So instead of seeing that greater tuberosity or the head of humerus very, very clearly, what we are able to see is the head of humerus like the electric bulb. So this second one is what you call as the posterior dislocation, right? This one has to be the posterior dislocation. Now, what all points you should remember about anterior dislocation and posterior dislocation? The anterior is the most commonest type, right? Anterior is the most commonest type. We know that. In the anterior, which is the most commonest variant, it has to be subcoracoid, right? It has to be subcoracoid. That is number one. Okay. And second, in the anterior dislocation, what happens to the contour of the shoulder? So you can very well appreciate this fellow as well. Contour for sure is going to be lost, right? Subcoracoid variant contour 100% is going to be lost in anterior dislocation. Third point, that when you are having a patient with anterior dislocation, this contour, once the contour is lost, now if you keep a scale on the shoulder here, the acromial, one part of the scale can touch the acromion and the other part can very well touch the lateral condyle. That clearly confirms that the contour is lost. And what do you call that sign? That is Hamilton ruler test. Okay, so this is okay, right? So this one, the anterior dislocation, it has to be subcoracoid. Contour of the shoulder for sure is going to be lost. That is for sure. It is going to be lost. Okay, and what is the method? How to reduce it? It is the most commonly used method is Cocker's method. Most commonly used method is Cocker's method, right? And on the top, the first and the most important thing about any of the dislocation to be remembered, it is always about the attitude, how this dislocation is going to happen. So always remember, anterior dislocation happens with abduction and external rotation. In the very recently conducted or these cricket matches, you all have seen Rohit Sharma reducing his shoulder, right? So whenever there is going to be anterior dislocation, it has to happen with abduction and external rotation. Similarly, this point, yes, team is the method in Cocker's. Team is the sequence of the steps you are going to do. From the next class, try to use the same software and quality or as Sakshi ma'am. Perfect. I'll ask her which software she is using and I'll use that. Thank you so much for the input. Now in posterior dislocation, please do remember attitude, how it is going to happen. It is adduction and internal rotation because of muscle contraction. And who are the patients where we see this kind of dislocation? Your exam question will be based on two patients, epilepsy and electric shock, right? Epilepsy and electric shock, because in these two conditions, what do we have common is the violent contraction of the muscles, and that subscapularis, that muscle in front of the glenoid and the head of humerus, when it contracts here, it is going to turn the head of humerus in, right? And the most important part here is that contour is usually normal. Contour of the shoulder is usually normal. So in your exams, you are going to get a question as a patient who is taking phenytoin for last so and so duration. Today morning, he had an episode of scissors. He fell down and now he has been stabilized. Vitals are stable. Patient is okay, comfortable, but he is not able to mobilize the shoulder, right? And contour of the shoulder is normal. Okay, so in posterior dislocation, do remember that is a very important difference between these two. Anterior dislocation, the contour has to be lost, and posterior one, it has to be usually maintained, right? So adduction, internal rotation, epilepsy, electric shock, okay, and contour is normal. And the most important point, like on X-ray, what you are seeing here, it is called as what? The electrical bulb sign, right? Electric bulb or the lighthouse sign. Okay, electrical bulb sign and the lighthouse sign. Empty glenoid. Okay, Dr. Jan is there. So empty glenoid is seen in less number of cases, but yes, it can be seen. That is the second step of this. First always is the electrical bulb sign, right? First one always is electrical bulb sign, and this is how the two shoulder dislocations are different, the anterior and the posterior. All right. So this definitely, and one important, very important thing, please do remember, whenever there is a question on dislocation of the shoulder, always remember whether it is an anterior dislocation, whether it is a posterior dislocation, or the third one, inferior dislocation, the complications of the shoulder dislocation for all the three, they have to be common, right? There are two important things. One, when they ask you what is the most commonest complication, whenever they are going to ask you the most commonest complication, please do remember it has to be recurrence. Once the shoulder dislocates, it will dislocate again and again and again. And if the dislocations are more often related to anterior side, then on the anterior dislocations, in all the shoulders with anterior dislocations, we can see two very classical lesions. One of the lesion is called as Bankart, right? Bankart lesion is, it is a name of a person only, right? And this is seen on the antero-inferior aspect of glenoid, right? That will be on the antero-inferior aspect of the glenoid. That has been your INA set question of the November 23 examination, right? Other one in the anterior dislocation, other than this Bankart, we can see Hill-Sachs lesion as well. Now, where is that Hill-Sachs? Hill-Sachs lesion is seen on the humeral head. That is a posterolateral aspect of humeral head. Okay, posterolateral aspect of the humeral head. So these are two classical lesions. Whenever the person is going to have the recurrence again and again, the head of humerus and the glenoid, they damage each other. And the damage, the defects on these two bones are labeled as Bankart and Hilsack. These are name of two different people, right? Who just did a lot of research on these two defects, and they gave some of their management options as well. So Hilsack and Bankart. Now, if they ask you, what is the most commonest acute complication? So please remember, the most commonest acute complication for any injury, it has to be neurovascular compromise, right? So most commonest acute complication, it is axillary nerve injury. And you know very well that if the axillary nerve will be damaged, what all muscles will not be working properly? It will be deltoid and teres minor, right? Along with the loss of sensation on the upper lateral aspect of the shoulder area. That is regimental badge sign. Okay, so most commonest complication and the most commonest acute complication. Just addition of a word acute, addition of the word acute is going to change your answer in the exam. So read the questions very carefully, right? Read the questions very carefully. So these are two about dislocation of the shoulder, right? Now second, other one, this is one of the question in the shoulder area which has been asked not many number of times in the NEET or INSET, but in the FMGE exams. Okay, here you can see one of the scapula is at the upper level, one of the scapula has descent down very properly, right? Failure of the descent of scapula is called as what? Failure of the descent of scapula, it is called as Springel's shoulder, right? It is called as Springel's shoulder. And this Springle shoulder, it can be an individual entity, or it may happen in relation to some other defects in the child. For example, if there is cervical spine fusion, like this area, you can appreciate that the neck is too short or the neck is not there, right? Too short or the neck is not there, then this is cervical spine fusion. This is cervical spine fusion, and some curve can be also appreciated on the back, right? So whenever any child has got the Springle shoulder, cervical spine fusion, and the scoliosis, these are making an entity called the Klippel-Feil syndrome, right? So Klippel-Feil syndrome is basically failure of the cervical spine to have the proper alignment, and they are fused. When they are fused, they are going to create the spinal scoliosis basically in the spine, the scoliotic deformity of spine, and the scapula, it fails to descend down, right? So this is Klippel-Feil syndrome. Springles can be a part of the Klippels itself. Okay, the Springles can be a part of the Klippel itself. Image based question for your exams. Then we have this one, the 3-point relationship, which has been very common. It has been asked in the recent year as well. So 3 points which are making the 3-point relationship. One is olecranon, one is lateral epicondyle, one is medial epicondyle, right? So very simple, you should know that what are the conditions which can break this triangle. All the fractures which are making the points here. So fracture of the medial epicondyle, fracture of lateral epicondyle, fracture of olecranon, they are going to destroy the triangle. And if the injury occurs above these condyles here, which fracture we just talked about, that the fracture supracondylar humerus, right? Fracture supracondylar humerus, it is not going to alter this triangle at all, right? It is not going to alter the triangle at all. So this is fracture supracondylar humerus, which is not going to alter the triangle, right? Always remember this. And in the case this olecranon from here shifts here, right? It is being pulled up. So now the triangle will be reversed like this. So reversal of the triangle, this reversal of triangle, it can be seen in which condition? When the olecranon goes up. And what you are going to call that situation? It will be posterior dislocation of the elbow, right? So posterior dislocation is going to reverse this triangle, right? Posterior dislocation is going to reverse this triangle, and the supracondylar humerus will not be touching the triangle at all. So triangle doesn't get hampered. It is not damaged at all, right? In reversal of triangle, which nerve can be injured? Reversal of triangle means it is a dislocation of the elbow. And in dislocation of elbow, it can be any nerve, all the three, out of all the median, radial, ulnar, all the three can be involved. But more commonly involved are the median and the ulnar nerve. Radial is the last one to get involved if there is a dislocation of the elbow. So it can be median, it can be ulnar, and radial at last. So any nerve can be involved here. Okay. So yeah, Arif, this was your question. Okay, so 3-point relationship has been an important one. Now this one you have already answered. Now this is supracondylar, right? This is the fracture supracondylar, and you all are expected to remember, identify this injury very, very nicely, right? Always remember, if I label this X-ray here, this is the AP view, this is the lateral view of the elbow, right? And here we can see, we can appreciate that. Here we can appreciate that this is ulna and this is radius, right? Radius and ulna, and there is a fracture fragment of the lower end of the humerus here, right? This is the supracondylar fracture here. This is the supracondylar fracture over here. And in the supracondylar, once there is a fracture happening here, this fragment, it usually goes on the backside, right? Once it is going on the backside, that is on the extensor surface, we are going to call it extension kind of supracondylar fracture. Extension type of fracture supracondylar humerus. 98% cases, 98% of the supracondylars, they are like this only, right? They are like this only. They have to go into the extension type. Okay, they will be going into extension type. So supracondylar, always remember the fragment goes back, right? That is the extension kind of supracondylar, and rest of the points we have already discussed in relation to this. Okay, now this one is how the lateral condyle gets displaced or rotated because of common extensor origin. That is why it is a fracture of necessity. Okay, coming on to this one, if you can identify now, the olecranon part, the rest of the ulna part, they have been displacing, right? And this is what you are going to call as the posterior dislocation of the elbow. This is what we are going to call as the posterior dislocation of elbow. Arif was asking the question, which nerve? This is the same thing what we are just talking about. Now here I want to just emphasize upon something. If along with the posterior dislocation, somebody gets an injury, fracture of this coronoid here and injury to the radial head here, posterior dislocation of elbow along with injury to the radial head, and along with the injury to coronoid. These three happening together, it is called as the terrible triad of elbow, right? This is called as the terrible triad of elbow. So Hotchkiss terrible triad, or the terrible triad of elbow, right? So posterior dislocation of elbow with radial head and coronoid, right? These three, when getting involved all together, that is terrible triad of the elbow. Okay, so please do remember, in the last year 23 exam, we have got a question on terrible triad of knee, and now this is about the terrible triad of elbow. Okay, so please do remember how it happens. All the three components of terrible triad, right? They are terrible triad of the elbow. Next, we have these two important injuries from the forearm area, right? In the forearm now, we have got two bones, the radius and the ulna. And what is the function they serve, the radius and ulna? They are the bones which give us the action of supination and pronation, right? These are two important bones giving us action of supination and pronation. Elbow gives you flexion extension, wrist gives you flexion extension, and the supination pronation at the forearm area, right? The very first X-ray, the X-ray A here, this is a X-ray B here, and what all we can make out in the X-ray A, there is a fracture of, there is a fracture of the medial bone, that is the ulna here, right? And the radial head is getting dislocated from here. The fracture of proximal one third of ulna with what is getting dislocated? Dislocation of the proximal radioulnar joint. Dislocation of the proximal radioulnar joint. And what do you call this injury now? Yes, it is not Galeazzi. This is not Galeazzi. The medial bone, the medial bone is for Monteggia, right? The medial bone is Monteggia. This one is Monteggia fracture. Okay, this one is Monteggia fracture. So medial bone, Monteggia fracture. Okay, now other one, just look at other side. And one very, very important point I want each one of you to remember all the time is Monteggia, when this radial head is getting involved here, right? Which is the nerve which goes behind the interosseous membrane winding around the radial head. It has to be the radial nerve, right? So Monteggia fracture is going to involve the radial nerve. Now, one very important point, it is not the radial, it is actually the posterior interosseous nerve, because radial nerve has already divided in front of the lateral condyle. That means radial nerve is not reaching to the head of the radius. It is the PIN which is reaching to the head of the radius. So answer has to be PIN. which is a branch of the radial nerve, right? If PIN is getting involved, what is the presentation of the patient? Patient will be able to extend his wrist, but he can't extend his fingers, right? But he won't be able to extend his fingers. So finger drop is the presentation of Montegia. Now, one very important thing I want to highlight: when there was a fracture of lateral condyle of humerus, when there was the fracture of lateral condyle of humerus, it was involving the nerve of the medial side, that is ulnar nerve, right? Lateral condyle fracture of humerus was involving the ulnar nerve, that is on medial side, and here the bone getting fractured is on medial side, Montegia, but the nerve getting involved is on the lateral side, right? So two cross areas where we have the maximum potential of getting the answers wrong in the exam. If some of the question tells you post trauma, the patient is able to extend his wrist but can't extend his fingers, right? So our all attention go towards the radial nerve or the PIN, and we try to find out the answer on the lateral side, right? But the answer is on the medial side. The fracture is of the medial bone. So two cross areas, please do remember, two cross areas, the most commonest done mistakes in the exam: lateral condyle, ulnar nerve; Montegia fracture, the lateral side PIN nerve, right? The posterior interosseous nerve. Okay, and look at the other X-ray. Fracture here of the distal 1/3 of radius, and the dislocation is of distal ulna here, right? Just reverse of the previous image, absolute reverse of the previous image. Now, what should I call it? The fracture of distal 1/3 of the radius, fracture of distal 1/3 of the radius, and along with what? With dislocation, with dislocation of distal radio-ulnar joint, with dislocation of distal radio-ulnar joint, and in distal radio-ulnar joint, it is basically distal ulna, right? It is the distal ulna which is getting subluxed. Okay, just reverse of the previous picture. So this injury is also called as the reverse of Montegia. This is called as what? The reverse of Montegia. And reverse of Montegia, the name for the injury is what? It is Galeazzi. Somebody was saying it. It is Galeazzi fracture. So reverse of Montegia or the Galeazzi fracture, right? So Montegia and Galeazzi, the reverse of each other, right? Reverse of each other. Okay, so these are two injuries in the forearm area. Okay, these are two injuries in the forearm area. All right. So now after this, these two. Now I can tell you something here. In your all the NEET exam till date, whatever has happened since the year 18, 19, 20, 21, 22, right? All the years we have got some question from the wrist area. Okay, this Montegia, this is classical Montegia, Archit. This is classical Montegia. Okay, there are Montegia variants as well. So this is called type 1 because you are calling it a classical Montegia. Classical means when there is a fracture also, when there is a dislocation also, right? So now this is Montegia and Galeazzi. Now from the wrist, I was telling you, around the wrist area, there is at least one question in all your NEET exams till date, right? There is a question which has come up in all your NEET exams till date, and from the wrist, first of all, let's just revise very, very quickly. What exactly is the wrist area? What exactly is the wrist joint? So in the wrist, when you look at the wrist area, this is distal radius. This is the ulna, which is articulating over here. And then we have the scaphoid bone. Then we have the lunate bone like this. So please do remember, out of these four, number one, radius, ulna, scaphoid, and lunate. Out of these 1, 2, 3, and 4, which one is not a part of the wrist joint? Which one of them is not a part of the wrist joint? So wrist joint is between the radius and the carpals, right? Wrist joint means the radiocarpal joint. I'm sure everybody can recall that. So this is the radiocarpal joint, right? Okay, so radiocarpal joint, which is making your wrist joint. Now, whenever you're talking about the fractures around distal radius, whenever you're talking about the fractures of the distal radius, they can be of two types, you know very well, and they can be extraarticular or they can be intraarticular, correct? They can be extra or intraarticular. When you talk about the fractures which are away from the joint area, like here, if this is the fracture line, these are called as extraarticular fractures. These are called as extraarticular fracture, right? These are called as extraarticular because they're away from the radiocarpal joint. And what all fractures do we know in this extraarticular? What all fractures we know in this extraarticular category? We have got two only. One is Colles, and other one is Smith. One is Colles, other one is Smith. Correct? Now, which one is Colles out of these two? Can you name? If I label these X-rays, if I just label them as X-ray A and X-ray B, tell me which one is Colles and which one is Smith? Which one is Colles and which one is Smith? What do you suggest? Which one is Colles and Smith? So X-ray A, what all you can appreciate here in the X-ray A, this is the shadow of the thumb here. This is the shadow of the thumb here. The first metacarpal. Okay, the first one, image A, should be which one? Colles and Smith, Prachi and Amit. Okay, Dr. Jain, D, G, 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 G. Okay, see, in image A, what is happening is the distal fragment here, distal fragment is facing towards the thumb, is moving towards the thumb. A is Smith, very good. This one, that is the reason it is a Smith fracture, right? It is a Smith. Sairish, it is not Colles, it has to be Smith. And B, the distal fragment here is facing onto the backside, right? It is facing onto the backside, and that is why this one is Colles. Okay, so in Colles and Smith, what is the difference? Difference is of the displacements. Difference is of the displacements. So which all displacements do we see in Colles? Which one displacement do we see in Smith? So do remember the displacements of Colles. You remember how many are they? 6 in number, right? They're total 6 in number. The lateral displacement and lateral tilt. Then I, how to remember it? LIDS, the eyelids. Remember the lids. Okay, black you want. I'll write with the black part. Okay. So LIDS are the way to remember them, the displacements of Colles, right? So LIDS, L is for lateral displacement and lateral tilt. I word is for impaction, right? Impaction, you all know about the impaction part. Then we have D, happened. Okay, so I is impaction. D stands for dorsal displacement and dorsal tilt. Okay, dorsal displacement and dorsal tilt, and S is for supination, right? So lateral displacement, lateral tilt, lateral displacement, lateral tilt. I is for impaction, dorsal displacement, dorsal tilt, and then we have last one as supination. Okay, so these are all. Now one easy way is take a lateral view of the wrist, take a lateral view of the wrist and just identify where is the distal fragment going. If it is going on the dorsal side, it has to be Colles. If it is coming on the palmar side, it has to be Smith, because Smith is what? It is just reverse of Colles. Smith is just reverse of Colles, right? Okay, right? Reverse of font size increase, but I write like this only. No, you can just enlarge the screen to see whatever is not clear. Just enlarge the screen, it will be much visible to you. Okay, so these are Colles and Smith, and please do remember how do you make a difference. So extraarticular fractures are two, the Colles and the Smith, and the treatment plan. And the treatment plan for both of them, whether it is Colles or Smith, the treatment plan has to be what? Treatment plan always and always is close reduction and immobilization. In trauma cases, open up your notes and you'll find out that there are 5 ways to treat them. There are 5 ways to treat any of the trauma case. Immobilization only, close reduction, immobilization, close reduction, internal fixation, open reduction, internal fixation, and last for open fractures, what do we do? External fixations. And questions on external fixators have been very common in your these recent year examination. How to identify anterior and posterior? Oh, okay, right. So see this. How to identify anterior and posterior? Sahana, you can have a look on this. This is the shadow of the thumb. See, whenever you look at your thumb, the thumb has to stay in front of your fingers. It can never go back. So whatever view of the X-ray you may take, the thumb has to stay in front. That means the thumb has to stay in palmar side. Okay, that is the anterior side. So in both the X-rays, if you compare, this is the shadow of the thumb in both the X-rays. That means where on the side, I'm just going to write, yeah, I'm just going to write small a, just this small a. This small a means it is an anterior side, right? It is an anterior side of the palm area. Okay, this is the anterior side of the palm area. So that means thumb is on the palmar side. So anterior side is palmar side. Now this is the way to identify if you are getting confused sometime, right? That's one easy way you have to identify this, right? Why don't you give PDF? So what you will do with the PDF, at least start making something, right? So which board is not clearly visible? Please tell me this, what I'm writing is not clearly visible. Okay, so just see, just go back little back from the video, and I hope that should be clear to you. So extraarticular fracture, please remember the treatment plan as close reduction and immobilization, right? The close reduction and the immobilization part that is required for Colles and Smith. Okay, as these are metaphyseal areas, impaction is common thing. How the steps, how do you manage? How will you manage the, just a moment. All right. Okay, now I think it should be good. Now it is showing me as a good one. That was 11:10. Fine. Okay, so Colles and Smith, these are the two most important injuries from where you are getting the questions again and again in all your exams. 2500. Okay, let me just do that. Uh, okay, to change the resolutions, I'll have to stop this relay, which will not be a good idea. Let's continue. This is part one. Sarita, for Colles and Smith, ORIF? No, you are mistaken then. ORIF is not required for Colles or Smith. Open reduction, why would you require open reduction? It is not a joint area. It is not a dislocated one, right? For this, okay. So I'll just clarify your this point. See, open reduction, these are two extraarticular injuries. What are the other two injuries which can happen in the wrist area? The other one is a intra. I'll use the black. Somebody said black color to be used. So what are the fractures which go into the articular area? Intraarticular means when you look at the distal radius, fracture goes like this or here like that. Intraarticular injuries, they are Barton. That is Barton's. Barton's is comminuted intraarticular displaced fracture. Comminuted, this is a comminuted, multiple pieces, comminuted, and then intraarticular, and which usually gets displaced, right? Comminuted intraarticular displaced fracture. And once this is a scenario, then you go for, I hope it doesn't get covered by my image, then it requires ORIF, right? So Sarita, please check your notes again. Just revise the notes again. Just go through it. If there is some mistake you have noted, please correct it. And the other one is Barton, and the other injury intraarticular is Schoffer, right? Other one is what you call as the Schoffer. Schoffer is what? It is a fracture of the radial styloid, right? This is a fracture of the radial styloid. So injury here, injury of the radius. I'll just remove this. So injury of the distal radius, right? So when you see the radial styloid, something like this, the fracture here of the radial styloid is what you simply call as the Schoffer, right? Same like Rolando. Yes, Sahana, you are absolutely right. Okay, so ORF for the fracture of necessity, absolutely correct. You require for the fracture. See, Prachi, I would like to correct you here. All the fracture of necessities, they don't require an open reduction, right? They don't always require open reduction. The fracture of necessity means all the fractures which require fixation only, which requires fixation. So please, for everybody's information, fracture of necessity doesn't always means that you have to go for open reduction. You don't have to open them all the time. Fracture of necessity means are those injuries which requires fixation all the time. For fixation, you might need to open the fracture. You might do it without opening it. Both the ways it is possible, right? Both the ways it is possible. So no need to worry about the opening part, right? Now, most commonest complication of the Colles, most commonest complication of Colles injury is the stiffness of the joint. Post trauma, the patient will not be able to mobilize the joint very normally. That is a stiffness of the finger, stiffness of the joint, right? Uh, might be I wrote wrong, so please correct it. If you have written wrong, it is only the Barton where you require ORIF out of all the wrist injuries, right? So this is from the distal radius area. So today it's 11:15 already, and I'm sure you all have your own plans as well, right? So this is let's make it a part one, because today we lost kind of 20-25 minutes in the tech part. but let's make it the part 1 of the images. And this is already 1 hour 8 minute session. I don't want to take much of your time, right? So I'll make part 2 again, and I'll inform you prior so that you all can make your schedules accordingly. And if these images, this image based particular session is okay for you, good for you, then definitely do let me know, right? So we are all there on the CTG group, we are all there on the Triple S group, so you can join your groups accordingly and you can be a part of those groups. So I'll inform you part 2, and if it is fruitful for you, definitely we can like continue for the second part as well. So go on with your own schedule, start with your studies, whatever you are doing, right? So let's make it another one, important one, right? So all the very best to all of you, and you all have to keep your notes ready when you're coming for this session. Okay, so thank you so much everyone, all the very best, and see you soon again with the part 2 of the sessions. Rest of the images I'll try to cover up from all the other sections: bone tumors, infections, pediatric disorders, joints, every other image I'm going to cover up there, right? Thank you so much for joining in, guys. All the very best to all of you.